Hi, and welcome to Neurocare Academy. My name is Dr. Trevor Brown, and today I have the pleasure of introducing you to Dr. Nash Boutros. Nash, how are you going?
I'm good.
Excellent, excellent. Thanks for joining us. Nash is a psychiatrist and a neurologist. He's the director of Electrophysiology Neuroscience Center, Deerfield, Illinois, and also adjunct professor of psychiatry at Rush University Medical Center in Chicago. Nash, different hemisphere of the world, and it's evening on Tuesday there. How are you feeling? You okay? Having a good day?
Yeah. It's nice weather. It's just beginning to turn cold, but the Chicago cold is not here yet, so it's okay.
Excellent, excellent. Nash, would you like to tell us a little bit about your background and the sort of where you grew up, your education, and a little bit about your clinical experience?
Okay, so I was born and raised in Egypt, and while at Cairo University Medical School, I was exposed to psychiatry, and I was exposed to, began learning about the brain in the physiology course in medical school, and immediately was fascinated by the complexity of the brain, and decided that that's what I wanted to do, is to practice somewhere in the brain. And then in the first year after graduation, I was rotating in the psychiatry outpatient, and I had an experience that basically determined the rest of my career. It was a family, father, mother, and their 16-year-old daughter. Looked like a standard middle-class family. They looked very decent family. They came in, sat down. So they looked so normal. So I asked them, what bring you in here today? Then at this point, the mother asked the father to leave the room. Then she asked the daughter to disrobe. And at that point, what I saw determined the rest of my career. She had cuts, razor cuts all over her arms and legs. And she had cigarette butts burns all over her abdomen and thighs. My hair stood on end, and I knew that she earned herself the diagnosis of borderline personality disorder. Then I started looking into what is known about this, and I immediately learned that we know hardly anything about this disorder. Lots of theories, but nothing concrete, no science. So at this moment, I decided I wanted to do research in the neuroscience of psychiatry. And that basically determined, then I had the opportunity to immigrate to the US, where I did psychiatry residency, didn't learn much about the brain. So I decided to do neurology residency and learned a lot about the brain, but nothing about the brain and behavior, that interrelationship. So I actually had to do a fellowship in epilepsy and a fellowship in behavioral neurology in order to learn what I wanted to learn. And that's rest of my career is practicing in that border gray zone between psychiatry and neurology.
Fantastic. What an amazing experience you've had, and what an amazing impact that patient has had on your career. I mean, we have your experience in psychiatry, we have your experience as a neurologist, and also we're going to learn today, if I may summarize, Nash, we're going to talk about some of your research. We're going to talk about some EEG waveforms that can impact cognition, that can impact psychiatry, but are not necessarily causing seizures and epileptiform behavior. So I've been really looking forward to chatting to you about this, and let's get started. Let's get stuck into it. So the first question I've got for you, Nash, is with all this interest in neurology, psychiatry, and human behavior, this has given you a unique view. And what are the three main research interests that you have been, that you have worked in over the past? And can you describe those for us?
Well, basically, the main line of research, basically, the entire research interest has been in the electrophysiology, psychophysiology of psychiatric disorders. But within that framework, there have been pockets of interest. So the big one is what we're going to talk about today, is the EEG abnormalities in psychiatric disorders. But I was also interested in evoked potentials, because evoked potentials are extremely interesting. It's the workings of the brain. The EEG is the sort of the background idol of the brain, but the evoked potentials are the actual workings, functions of the brain, and also other electrophysiology like magnetoencephalography and polysomnography. So I now would like to share my slides with you. And I have no conflict of interest. And wanted to start by these three main headings, the abnormalities of EEG and do they impact behavior? And are there specific psychiatric disorders that have more preponderance of EEG abnormalities? And the issue of TMS, depression, and EEG. But let me start by making a statement that the clinical EEG, that's when you record the brain activity and some physician looks at the EEG with their naked eye to find abnormalities. And that is not where the major expansion in electrophysiology and psychiatry is going to be, but it's the basic essential first step. It's a skill that anybody who works in EEG must master and be comfortable to know what is EEG and what is artifact, what is garbage. So garbage needs to be removed from the signal before we further process the signal. For the longest time, the field of quantification of the EEG suffered from the statement of garbage in, garbage out, because people allowed garbage to go in. So that's where the clinical EEG comes in. It's an essential first skill. The clinical EEG is actually widely available. You can get a clinical EEG almost anywhere, even in small villages or remote areas. It is completely non-invasive, and it is relatively cheap. Now, what the EEG tells us or shows us two kinds of abnormalities, either slowing of the background activity of the EEG, and that usually reflects some damage where the activity has slowed down. But the other major kind of abnormality is when you get what is called paroxysmal activity. That means now you see it, now you don't. It comes and goes. The EEG is ongoing, looking normal, nice. Then all of a sudden you see an epileptic or epileptiform or epilepsy-like activity. So sharp wave or a spike or polyspike or any of that family of what is called paroxysmal activity. And what I firmly believe that paroxysmal activity reflects hyperexcitability about the cortex. The area where this activity is coming from is hyperexcitable. At a certain point, that hyperexcitability reaches the point of causing a seizure. And that's the tip of the iceberg, what you see here. But that's only the tip. If the activity is less than severe enough to cause a seizure, it will not cause a seizure, but it causes disturbance in the neural circuit where it exists. And that gets reflected in behavior, and that is highly likely because a whole third, 1/3 of the entity is dedicated to behavior. So if this abnormal activity comes from anywhere in that 1/3 of the brain, it will then, the behavior that is coming or emanating from that part of the brain will become abnormal. Now, the second part here is when the activity is strong enough that we can actually see it at the scalp. The skull is our enemy because it's an electrical resistor. So activity beneath it, inside the skull, is harder to see on the outside. It has to be large enough for us to see it on the outside. But there can be abnormal activity, epileptic activity under the skull that we don't see it. And we know that because when we record in patients who are undergoing evaluation for epilepsy surgery, we have electrodes on the outside and we have electrodes inside the brain. And we see both sides of the skull. And we know for a fact that there is a whole lot more going below the skull than we can see outside the skull. And in the large part of the bottom of the iceberg here is when the hyperexcitability is not even enough to cause an epileptic discharge, even if it's undetectable, but it still can affect these circuits. These circuits in the brain needs to be healthy for the behavior that they are responsible for to be healthy. Now that takes me to, so in general, if a psychiatric patient is difficult to treat, patient comes in with depression and they're not responding, you've tried cognitive behavioral therapy and you've tried one antidepressant, you've tried the second antidepressant, and they're not responding, then there might be a cause for that. That's when the EEG might be useful. That's general. Somebody with psychotic symptoms. Atypicality of the presentation or difficult to treat are usually the two clues to want to work the patient up further. There are a certain list of psychiatric disorders where there is actually increased preponderance of these epileptic discharges in the typical patient. So on top of the list is the autistic spectrum disorders, panic attacks, and any dissociative episodes, repeated aggression, particularly if unmotivated, treatment unresponsive ADHD, and atypical or rapid cycling bipolar disorder. Actually, the more rapid the cycling, the more likely you find EEG abnormalities. So to talk a little bit about panic disorder, which is more or less the prototypic example of what I'm talking about, this a little bit of increased hyperexcitability without the presence of actual epilepsy. Panic attacks carry a lot of similarity to complex partial seizures that are coming from around the Sylvian fissure, whether fear, derealization, depersonalization, tachycardia, diaphoresis, abdominal discomfort. These are all symptoms that actually occur in complex partial seizure when they are happening from around the Sylvian fissure in the temporal lobe. And I'm not saying that these panic attacks are actually seizures, but if you, like we just said, if that tissue where all the emotions and feelings are coming from are hyperexcitable, then our response is going to be abnormal, and it could take the shape of anxiety, panic attacks, or phobia, or any kind of psychiatric problem based on where the activity is coming from. So, given that this knowledge is not new, this is actually old knowledge that panic attacks can be accompanied by EEG abnormalities, particularly epileptic type abnormality. This has been known for a long time, and there is like a very long, very big literature on that. But that caused people to say, okay, if this is the case, then they should be responsive to anti-epileptic drugs. And the literature suggested that there are, in fact, two groups, and this is the paper where we reviewed that literature, suggested that there are two sets of patients with panic attacks. The ones with actually abnormal EEGs and the one without abnormal EEGs, or when you just don't search for abnormal EEGs, just take a heterogeneous group of panic patients. When the investigators looked at the EEG of panic patients, they tended to treat the patients with abnormal EEGs with the carbamazepine family of medication. And the response here was very strong. 17 out of 20 patients in the literature responded well. Before we get there, but the group of patients with panic attacks that do not have EEGs, abnormalities, tended to be treated with the valproic acid type of medication. And they also responded, but the response rate was different. So when EEG is abnormal and treated with the carbamazepine family, the response was very strong. When they have no EEG abnormality and treated with the valproic acid family of medication, there was still a good response rate, but significantly less than the other group, suggesting one of two things, which can be tested in research, that maybe abnormal EEG is a predictor of good response to anticonvulsants, and maybe the carbamazepine family are superior. Both are testable hypotheses. Brings me to the issue of autism. And what is that is a large literature, but started only in the late 70s. Up to the late 70s, autism was seen almost entirely as an upbringing problem, emotional attachment issues. There were all kinds of attachment theories, and it was seen as there's something wrong in the upbringing that caused these kids to be that way. In the late 70s, case reports started coming out that showing that they can have significant epileptic activity on their EEG, even if they never had a seizure. So then from case reports, then it starts having in the 80s case series. Then in the 90s, we started to see large groups of patients. And that's, again, it's a significant literature. And till the early 2000s, the question became an important question, which is, should we screen, if somebody is diagnosed with ASD, should we screen them with an EEG, even if they never had a seizure? And the field of neurology oscillated on that, back and forth. And they felt that, well, if the kid never had a seizure, you get an EEG, you find a epileptic spike, you're likely to gonna give him anti-seizure medicine, and these are dangerous medicines. forgetting that if the brain is having these epileptic spikes, that's a far more dangerous thing to not pay attention to. So in 2017, Ron Swartzena and his group, I'm included in that group, started looking at the EEGs from their own private practice. And they looked at a large number of non-epileptic autistic patients, 140, and they found basically a third of them to have epileptic discharges. That's very significant. Then we came back in 2000. Then we concluded from then that these abnormal electrical activity can be causing, impacting global development, cognitive functioning, and behavior. And by adolescence, a third of these kids are going to go ahead and actually manifest a seizure. So why not discover it 5, 6, 7 years earlier and pay attention to it? So we came actually in 2019, the bottom paper. We then reviewed that literature again, and we concluded rather positively and affirmatively that the available evidence support the need for EEG screening for every kid diagnosed with ASD as part of the assessment. Just I would like to point that this particular paper in 2019 was published in European Child and Adolescent Psychiatry, which is a rather high impact, very difficult journal to publish into. This paper was subjected to significant scrutiny before it actually got published. Well, then the same question that happened with panic attack, of course, happened here. If you're telling me these kids have too many epileptic activity, do they respond to anti-seizure medication? And the available literature is limited, which is a problem, but the available literature, limited as it is, all point in the same direction, that yes, they do. There are uncontrolled studies. This is basically the only controlled study by Hollander. And they showed that there is significant impact of valproic acid on the repetitive behavior with a large effect size. One thing I wanted to, before we get into ADHD, the one important thing in almost all psychiatric disorders, they all heterogeneous. There is not a single psychiatric disorder that is all homogeneous. So autism is no different. It's a very heterogeneous group of patients. And this is one big variable, the presence of epileptic discharges. And it's easy to detect. So when I review papers on pathology or physiological or anatomical changes, I see that till today, they just put everybody who received the diagnosis in without controlling for that one rather easily detectable variable, which I hope that future studies will actually pay attention to that. Bringing me to the issue of ADHD. So the thing about ADHD is that there is significant literature that shows that there is about a third of these patients have EEG abnormalities. But on the other hand, most of the patients do well with just a psychostimulant. You give them some Ritalin or amphetamine, and they do well. So if you give them the medication and they do well, then perhaps that's okay. But there is a good percentage, maybe a third, that will not do well with psychostimulants. And in that case, it would be good to obtain an EEG to see maybe you need to have a different policy. This is all literature showing the high prevalence of EEG abnormalities in that group of patients. But this next paper here is very important. It's from 2001 and is yet to be either replicated negatively or positively. But they showed, this is Sarah Hemmer, she showed that if the EEG is already abnormal before you start the psychostimulant, there is a 10-fold increase in the likelihood of a seizure occurring. So it's a good piece of information. You could find it easily. And if you know that piece of information about the child, at least you will watch out for this eventuality, not miss it if it happens, inform the parents about it, or avoid the medication altogether. So again, for the ADHD, if the patient is not responding to psychostimulant, if there is history of epilepsy or significant head injury, or if the clinical suggestion, if the clinical presentation suggests petit mal. And let me just say 2 words about that. Petit mal is when the patient stares in space. And the correlate in the EEG is a 3 per second spike and wave. And that's very easy to see if it happens on the EEG. And you can easily reproduce it by hyperventilation. Now, normally it will take this kind of activity 3 to 4 seconds of continuous happening in order for the clinician to observe the staring. But like everything in nature, nothing happens in a very specific way all the time. So if you're only having half a second of this activity, you will be completely disconnected from the world during that half second. And if this is happening 5 times a minute throughout a whole lecture or a class, you're sitting in the classroom, the kid is sitting in the classroom, getting disconnected every 15, 20, 30 seconds, cannot follow the teacher, cannot understand what's going on. They think they are stupid. Nobody understands why they cannot understand. They think they're stupid. They get with the wrong crowd. What I've seen from my own experience, they get into drugs and their life is ruined. Now, if you make the diagnosis of ADHD and give them psychostimulants, then they're likely to still get better because psychostimulant will desynchronize the cortex, which will decrease that activity. But you're treating the wrong disorder with the wrong medication, and there is that increased likelihood of eventually having a seizure. So again, the EEG is cheap, non-invasive, and is everywhere, so why not? This is, if we go back to the panic issue or the anxiety issue in general, and it's simple, it exemplifies the idea of the increased excitability. This is the glutamatergic tone in the cortex. When it's very little here and there is anxiety symptoms, maybe psychotherapy, a little bit of SSRI, but once the glutamatergic activity increases and the cortex is indeed hyperexcitable, this is when benzodiazepines, as again, the GABAergic activity, or an actual seizure medication will be needed. This is a flow chart, and I don't want to spend a whole lot of time on that I use for panic patients when they present. uh, this is a key issue here, that in order for me to consider this panic patient on the epilepsy spectrum scale, it needs to happen that the panic attacks come out of the blur, unexpected, not anxiety getting worse and worse and reaches a panic stage, but they come out of the blue, all of a sudden, boom, it's a panic attack, or occur during sleep. If the patient wakes up from sleep in a full-blown panic attack, I take that to the bank. In my practice, I get an EEG because, again, it's so easy for me to get one. But again, if you start the patient on an SSRI and they do so well, then probably no issue. Now, if my basic EEG is normal, I administer a scale called the SCIPS. And the SCIPS is, I'll tell you what that stands for. I have to write it down because it's very long. It's Structured Clinical Interview for Complex Partial Seizure-like Symptoms. Now, the scale is available on the internet. Anybody can find it, but I will be so glad if somebody emails me asking for a copy of the SCIPS. I will send you, it's available for free, so that's not copyrighted. I'll send you the literature that supports it. So if the EEG is normal, I administer the SCIP, and if the SCIPS is low, not very elevated, then I just keep trying SSRI, SNRI, nothing works, I add valproic acid. So if the SCIPS is high, then my suspicion is high. I repeat the EEG after sleep depriving the patient, and I have extended hyperventilation. If the EEG remains normal, we're back to this line. If it becomes abnormal, then we go to this line. And depending on the kind of abnormality, you work up the patient, whether you get an image, MRI, or treat with, if it's epileptic activity, then I would use a medication from the carbamazepine family. But again, when patient unresponsive, you're gonna try everything you have available. So the TMS, that's transcranial magnetic stimulation, it's one of the many forms of rapidly advancing neuromodulation techniques. And where that is so exciting, I'm so sad I'm at the tail end of my career, because I think in the next 20 years, it will be fascinating to see how neuromodulation revolutionize the whole treatment in psychiatry. Because with neuromodulation, you don't have to give a medication that goes systemic and affect the entire brain. You can target the left side, the right side, the medial side, the frontal lobe, the temporal. You can focally modulate brain activity. With fMRI and PET scanning available, we can pinpoint where the problem is, and we can go ahead and treat that part of the brain. It's just fascinating. Now, we've known from long time that the ECT, that's electroconvulsive therapy, which again, another neuromodulation that have had a bad rap because of the one movie, One Flew Over the Cuckoo's Nest. But we've known that ECT raises the seizure threshold. So does TMS, raises the seizure threshold. So if there is epileptic activity in the brain and you raise the seizure threshold, then that epileptic activity is less impacting on the brain. The brain will be less responsible or less excitable when you raise the seizure threshold. So this is a study that we conducted a while back now, when the TMS was beginning to become common. We did not know how TMS impacts abnormal EEGs. And from this study, it's not a controlled study, but it shows that if there is a minor EEG abnormality, that should not prevent you from administering TMS. But there was one case that we reported in that report where there was minor abnormality at the beginning and kept getting worse as we gave as we gave TMS, to the degree that we got scared. We did not wait until the patient had a seizure, but we got scared because it was just getting worse the more we administered TMS. But it's sort of a warning that, again, having an EEG, it's non-invasive, it's non-expensive. Why not have it in the background and know that you're dealing with somebody who does not have an abnormality?
So look, just to summarize a little bit, Nash, the combination of psychiatry and neurology has led you to understand that there's epileptiform activity in the brain, which is increasing psychiatric symptoms, and your ability to be able to identify that through EEG leads you also in your clinical practice to be able to use families of medication which have anti-convulsant properties and be able to treat some of those symptoms with that extra window into the brain of EEG activities. So it's a great tool to have in your back pocket, really, isn't it? As a neurologist as well as a psychiatrist, and seeing your flowchart there of how you actually go through the stepped procedures there is really informative for us all. So thanks for that. And I understand you've also undertaken some research regarding the anticonvulsant properties of sertraline. And this study here, iSpot, is one of those studies. Can you tell us a little bit about that?
Right. So this is a major, rather large multi-center project that Martine Arns has pulled me into. They have collected these EEGs from a large number, as 1,000 patients with severe unresponsive major depression that got randomized to escitalopram or sertraline, both are SSRIs, or venlafaxine, which is an SNRI. And they looked at their EEGs before treatment and 8 weeks into the treatment. Now, before we do anything, they asked me what my expectations were. And I said, well, abnormal EEG, whether the background activity, a decrease in the background activity, or the presence of isolated epileptiform discharges. Let me just make sure everybody knows what I mean by that. Isolated epileptiform discharges means patient have epileptic activity, but never had a seizure. That these will be associated with non-response to antidepressants. Like the same thing we found before with panic attacks. So we assume that would be the same with depression. In fact, only, in fact, that was true, but only for venlafaxine and escitalopram. That was the big surprise of this finding. Was not the case with sertraline. And that was, to me, was a big surprise and a very important and significant finding. So abnormal EEG implicate non-response to escitalopram and venlafaxine, but response to sertraline. And that was, now we had to go into the literature and see is there something to explain this? And indeed, we found that sertraline had higher dopamine affinity via the dopamine transport inhibitory activity and higher D2 receptor affinity. Patients that do not qualify for TMS then could be trialed on sertraline based on this finding. We also found there were, we looked at those who had abnormal EEG at the beginning, and we found that all three medications tended to help the EEG normalize. So in complete contrast to the old tricyclic antidepressants, that all of them made the EEG worse, the SSRIs or SNRIs, not only they did not do that, but the EEGs tended to normalize. Now, the big surprise came that those who were with sertraline, their clinical response was so much better. If their EEGs were abnormal and they were started on sertraline and the EEGs normalized, their clinical response was so much better than the other two groups. So I think that's another very interesting finding. And I must say, these studies need replication. It's very hard to replicate because the size of this particular study was so big, so it would be very hard to replicate. But nonetheless, replication is a must with science. And this is the slide that shows the response rate in the sertraline patients versus the other two medication groups. Again, there was nothing new here. We found that the literature already bears that out. Robert and colleague found a decrease in seizure frequency as a result of antidepressant treatment in depressed patients with comorbid epilepsy. That was irrespective of the improvement in mood and equally held for SSRIs and SNRIs. So that's exactly what we found in our study. In animal models, antidepressants, and there were 2 SSRIs that were tried in that literature and showed a similar decrease in seizure frequency. So the message here to psychiatrists worldwide, don't be afraid of SSRI or SNRI if your patient have history of epilepsy. It will not make that worse. It may even make it better.
Wonderful information there about how to treat epileptiform activity, and especially with antidepressant medications, and then it can decrease the epileptiform activity or the paroxysmal rate in the EEG as well. So in your clinical practice, how do you find paroxysms and EEG slowing? Do you work with QEEG at all?
Yes, indeed, that's the way it should be. We should pair the standard EEG interpretation with the QEEG expertise. As I began at the very beginning, with the fact that the future expansion will be in the techniques like quantification of the EEG, particularly now that we can have up to 200 plus electrodes on the head. You can pinpoint the sources of the abnormal activity. You have magnetoencephalography that sees smaller abnormalities, deeper abnormalities, and then evoke potentials that actually test specific functions, cognitive functions of the brain. So, but the standard EEG, the visual inspection of the EEG, till today, is the only reliable method of detecting paroxysmal activity. The reason is they come and go. In less than a second, you'll see the epileptic spike, which may be 200 milliseconds, 300 milliseconds, and it's gone. And you could have a recording of 45 minutes where you only see one of these episodes. So you need a clinician who is quite comfortable and trained in detecting these paroxysms in order to accomplish that. The detection of paroxysmal activity tends to be best when the patients are drowsy or falling asleep. So a lot of times you have to repeat the recording following sleep deprivation. Hyperventilation and photic stimulation can bring these further. So my rule is, if the standard EEG is perfectly normal, then I pass it on to my quantifying colleague to tell me what they find with the magnifying glass of the computer.
Great. No, that's fantastic for us to just confirm that for people, that to find paroxysmal EEG, you can't do that just with the QEEG. You actually have to have a trained person, trained neurologist to identify the waveforms, because they are so transient.
Or trained psychiatrist.
Or trained
psychiatrist. I'm in the business of trying to encourage psychiatrists to learn how to look at these standard EEGs.
Fantastic. And what sort of information? So if you've seen a normal EEG from the raw continuous EEG and you pass it on to your QEEG specialist, what information do you then gather from the QEEG?
Well, basically, any evidence of organic involvement of the brain. If there's clear focal abnormality, one side or the other, or one location or the other, that's one. Then any additional information. The world of connectivity is growing fast. Something like autism, that's the main abnormality you frequently see, is there a connectivity issue. And a lot of that's still in the research arena, but I rely on my QEEG colleague to tell me, yes, the left frontal lobe is 4 standard deviation slower or faster than the control group. And whether, if it's an ADHD case, whether it's slower or faster may actually indicate the kind of treatment you give. So it has clear clinical implications.
Thanks. Excellent. So obviously there are different tools that give us different information there, and to have access to both is wonderful. So now we can move on to what is really your speciality in identifying some examples of EEG patterns that are considered abnormal, and they would impact cognition, but are not necessarily provoking seizure. And so they would be of concern to a neurologist, of concern to a psychiatrist, because they could be provoking symptoms, and we can see them in the EEG without necessarily having a history of seizure in the family or in the individual. So perhaps we can move on to a bit of a lesson into identifying some of these. Thanks, Nash.
Okay, so again, that's the definition of isolated epileptiform discharges. And let me start by explaining what these potentials here, they're called controversial waveforms. That's a term used by psychiatrists, psychologists who believe they represent some form of abnormality. I believe they all represent some form of increased excitability of the cortex. These same variables are not considered abnormal by the field of neurology, and they tend to not identify them or report them, which is very dangerous situation. That's why the psychiatrist or psychologist need to be aware of them and demand they be identified and reported. Any neurologist who fellowship trained will know how to identify them. So, and you can notice that each one basically has 2 names. So the first one on top of the list is the 14 and 6 positive spikes / stenoids. So I use the term 14 and 6 positive spikes because I believe they are abnormal. Those who do not believe they are abnormal use the term stenoids. the 6 per second spike and wave if you believe they are abnormal, phantom spike and wave if you don't. So it's within the community of EEGers, the majority actually, because the majority are neurology, and none of these reflect neurological problems. They don't reflect epilepsy. They reflect behavioral problems. So most neurologists simply do not report them and tend to ignore them. And I will go very fast. The purpose here not to make the viewer an expert on detecting these, but to show that they are not easy to detect. They tend to be small in magnitude, and if you are flipping the pages really fast and you don't really care about them because you don't think they mean much, then you're likely not to even detect them. So that's called the 6 per second spike and wave. There are two forms of it. The fold means female, and it's more it's a lower amplitude during drowsiness. And there is then another form of the 6 per second spike and wave called the Wham, which during wakefulness and mainly in men. This is has more clear epileptiform activity, and some authorities have seen seizures with this particular pattern. But if I see it, I will ask the patient or the family about history of seizures. I don't really expect to see it. This is what's called the small sharp spikes, and the non-believers would call it the benign epileptiform transients of sleep, or BETS. The most interesting, you can see they are really small, and somebody could consider them artifacts. So if you're trained to see them, you will detect them. And let me tell you what is the most interesting thing about this particular abnormality. The major correlate of it is suicidality. And that is yet to be investigated in large, multi-center controlled studies or even treatment studies. But that literature that links the presence of small sharp spikes with suicidality is sitting in the literature, and I'm hoping some young, energetic person will want to do something about it. This is called the rhythmic mid-temporal discharges, and this is abnormal activity right in the middle of the temporal lobe. And all of these activities, this is called the wicked spikes, they sharpish looking, alpha looking activity. And all of them, including the last one that I will talk about, which is the most controversial, is called the 14 and 6 positive spike. These are here, the 14 and 6 positive spikes. Now, this particular channel, if you don't have this particular channel, this is a special channel that is set up to detect this particular abnormality. If you don't have it, that's all what you have is this activity here, which is much less prominent than this. So if you are not out to detect it, and you don't have this particular setup where you go from one side of the brain, T5, to the other side of the brain, A2, in order to magnify it, then you will not detect it. So let me go back one slide and show you this is how we detect this abnormal temporal activity. Any abnormal temporal activity will be magnified if you use this montage called Queen Square montage. It's basically a double banana, standard double banana, but at the end of the temporal run, this is 1, 2, 3, 4. Then the fifth, you go from T5 all the way to A2. And on the other side, you have the right temporal run. At the end of it, you go from T6 all the way to A1. Like you have two magnifying glasses on the temporal lobe to maximize the ability to see what's going on in that very important part for behavior. Now, all of these controversial waveforms, their correlates are exaggerated feelings. Like if with a small sharp spike suicidality, that's exaggerate, like depression, bad. You get a lot of somatization with these symptoms, a lot of impulsivity with these symptoms. They do not correlate one-to-one with a specific diagnosis. They just vaguely correlate with increased psychosomatic abnormal behavior, not in an easy way to link to the DSM diagnosis. Now, this is not controversial now. This is when the entire EEG is slow, and you're going here, EEG, and then the whole EEG gets dominated by theta or delta activity. Or you see focal abnormality. And detecting any focal abnormality on the EEG is a red flag, and the treating clinician must know, why is there focal slowing in the EEG? The answer is very simple. You get a CAT scan, an MRI, it's normal, you document that, and you're okay. This is what we talked about earlier, the 3 per second spike and wave. This is the correlate of absence attacks. This here would be an absence seizure. This is 1, 2, 3, 4, 5, 6, 7, 8 seconds. If this person is having this in front of me, I will detect they are having an absence attack. But if their activity ends here, just having this, then I probably will not detect it clinically. And then they're going to have another one here, which I will also not detect. And that could happen 30, 40 times in 1 minute. And this child is sitting in the classroom getting disconnected from the teacher every 10, 15 seconds. They're not understanding what's going on. They're going to get antsy, hyperactive. Everybody else is focusing and learning something, and this person is not. And they're going to think they are stupid. They're going to get depressed. And I assure you, going to get with the wrong crowd, and they going to be mislabeled something or the other. Now, how frequent is this?
Can I just ask a question, Nash, before you go on to the frequency of that? For those people who don't know about montage, because it's a difficult concept to understand for somebody who's not in EEG, to have an EEG wave, you need the difference between the active electrode and a reference electrode. And in standard EEG, you'll have these different montages, which we call a bipolar montage or a Queen square montage, etc. And they're different ways of placing the electrodes, aren't they? Which give us a focal point or different advantages or disadvantages in the EEG. Whereas with quantitative EEG, often we'll have a linked ears reference just to the back of the mastoids or the earlobes, or we'll have an average reference of all of the electrodes together so that each single electrode is referenced to a global average. But this makes it difficult to have very focal EEG in that respect with an average reference montage. So that's really why, and correct me if I'm wrong, why it's so good to have a neurologist's viewpoints with all these different montages to be able to specifically see these EEG morphologies. but also do QEEG to be able to see global slowing and connectivity and things that you mentioned before.
Right. So my standard practice is that I instruct my EEG technician to begin the recording while the patient is awake and fully cooperative, to record the one montage with the average electrode that can be used for quantification at the very beginning. And we got this set of data that we know we can quantify. Then we began to go into the different montages after that. And then we allow the patient to fall asleep because we want drowsiness and sleep, and then do hyperventilation, fluid stimulation. After we are comfortable that we did collect our basic signal that we can quantify.
Great. Thank you very much for just confirming that and the way it's done in your clinical practice. And so then you were talking about these absence attacks and the frequency of this?
Right. So there is very little literature on that, but the literature suggests that maybe 1 in 100 of the kids diagnosed with ADHD may have this. It's very little literature, and it might be more. I do not know that. But even 1 in 100, given that the EEG may give you all kinds of abnormalities, you're not specifically always looking for this pattern, and it's non-invasive and relatively inexpensive. I feel, why not obtain it? And in the outside chance that that's what's going on, at least you'll have the correct diagnosis and you will treat with the correct medication. So, in summary, what do EEG abnormalities tell us? Standard EEG abnormalities. If you happen to send the patient for an EEG and you get epileptiform discharges, that is always great news for the patient and the family. It's not bad news like in neurology. Oh, it means you have epilepsy. In psychiatry, it means you got something that we can treat. That it's always very welcome news from both the patient and their families, and suggests that maybe the use of mood stabilizing anti-convulsant. If anti-convulsant has no demonstrated psychotropic value, I wouldn't use it. But there are many anticonvulsants that have demonstrated psychotropic value, and that's what I would use. Choose one of these. If there is diffuse slowing of the EEG, that is the most common abnormality you see in psychiatric patients, is that the whole EEG is slowed down. And the most important thing is to make sure we are not doing this to the patient by over-medicating them. If that's the first thing, I would look at how many medication patient is on, what are the doses, and if I decide, no, 10 milligrams of Haldol or 5 milligrams of Haldol, 10 milligrams of this, or, low dose of, 2 milligrams of risperidol, okay. That's not enough to slow the EEG that I see it with the naked eye. There must be something else going on, and I work the patient out for a metabolic disorder. A lot of times it's thyroid deficiency, some vitamin deficiency, you work the patient out. If you find focal, anything focal on the EEG is an absolute red danger sign. So I get an image of that brain. If it's negative, that probably means it's an old head injury that the CAT scan doesn't see it, or MRI may show you some mild changes. Then I go to neuropsychology to tell me what is the functional correlate of this EEG deficit. And you get surprised from neuropsychology, because what frequently happens is that there is damage focally in the brain. the brain develops ways to get around its own deficit. And a lot of times that getting around may look to us as abnormal behavior. And we're very good at labeling people with all kinds of labels, but you will know from neuropsychology that this patient have difficulty processing and auditory and the visual, somatosensory. They have difficulty with cognition here, there, or the other thing, frontal lobe dysfunction, and you have a better understanding. I use the term biopsychosocial understanding of the individual patient. We're basically these two books here are in the market, and they will answer any question about EEG and psychiatry.
Fantastic. Well, that was so informative, Nash, and these two books that you've been involved with as well for anyone looking to delve deeper into this, I'm sure these will be very informative for them. But it just fills us with, I guess, some hope and some promise that with looking into the brain through EEG, there's the ability to stratify patients to a certain medication and get a result for them faster than if we were to do it just on a trial and error basis. So, slowing individual alpha peak frequency of slowing, paroxysmal EEG, they can inform us about ways of treating. So, look, I really appreciate your time, Nash, and I think it's a wonderful field of exploration for the next generation coming up. Is there anything you'd like to say to the next generation coming through? What's your dream of how this could evolve?
Well, actually, my big dream is to encourage more and more psychiatrists to learn about electrophysiology of mental disorders, because that is a huge literature. Every one of these modalities we talked about, whether the clinical EEG, whether the quantification of the EEG, whether evoked potentials or magnetoencephalography, each one of these is a huge literature in psychiatric disorders. And sooner or later, they're all going to come to fruition and impact the way we diagnose and manage our patients. And imagine the parallel field of imaging with fMRI, SPECT scanning, MRS, magnetic resonance spectroscopy scanning, and PET scanning. So the well-trained clinician will be able to see the patient and then order psychology testing, neuropsychology testing, some electrophysiology testing, some even serum blood testing or CSF testing, and some imaging, and actually pinpoint which gyrus is the one that went wrong, which lobe where the problem is, and then use neuromodulation to specifically treat the patient. I think the future is just so amazingly fantastic. I just wish I was 30 years younger to see it all happen.
Oh, look, I wish you would stay in the field another 30 years as well, Nash. But look, thank you very much for, giving us so much of the wealth of experience that you have to share with us all. And I wish you all the best. You're still in the field. You're still practicing?
Yeah.
Great.
I'm still doing electrophysiology, and I consult on some psychiatric patients. But at 72 years old, I deserve a little bit of leisure time.
Yes, you do indeed. Okay, well, we'll finish it off there. And thank you very much for your time, Nash. And we look forward to sharing this with the world.
All right. Thank you.